The chromosomes are an extraordinary collection of crucial nuclear material that have the principal assignment in the development of a new human to set the scene for what features indeed will be present. The 1,000 or more genes that are on each chromosome are expressing themselves in various combinations to produce features of importance, items as basic as whether it's a boy or a girl, whether the eyes are brown or blue or green, whether you'll have brown hair or black hair or blonde hair, curly or straight hair. Genes determine the color of your skin and your facial features, such as a cleft chin or high cheekbones. And to some extent, your genes help determine larger things, such as your athletic ability or your temperament. The expectation is built around the usual actions of 46 chromosomes. On the other hand, it is obvious that there are variations from that. One of them is the presence, for example, of an extra chromosome that stayed behind in the division. That 47th chromosome has its own directing materials, and they too will be felt in the final creation of the human. When that extra chromosome is number 21, that combination, or trisomy 21, produces a person with what we have now come to call Down syndrome. Parents looking at their new baby with Down syndrome are sometimes caught by the seeming crucial nature of the threats to that child's best progress. And at first it seems like the assignment is bigger than they can handle. One can dwell on ears that are kind of special, or a nose that is intriguingly stubby, but there is a brave spirit that is mixed with all of those that will more than carry the day.
We decided to have an amniocentesis, and from that's how we found out that we were going to have a child with Down syndrome.
I kind of knew when she was born, and she was born by C-section, and the doctor pulled my husband to the side and talked to him, and then I asked him what they said, and they said they suspected that she had Down syndrome and they wanted to do the karyotype.
And they said, we think there's a possibility that your son has Down syndrome. And at that point, we just kind of froze. My husband walked out of the room. My mother just kind of stood there, and we just hugged and cried. We couldn't believe it. We never thought anything was wrong.
But he got sick pretty quick. So my whole emotions shifted. Both of our emotions shifted. We no longer were so concerned about the Down syndrome part. We're more concerned on the health part.
I mean, it was like you thought you were going to have a child that was going to be a healthy, normal child, and then all of a sudden that was not there. And although rationally in my mind I knew differently because of my work with people with mental disabilities, at that exact moment when I was told, it was as devastating as it would be that you weren't going to have a child to some extent.
They also did an echocardiogram because of the oxygen level in the blood, and they saw the hole in his heart. That, coupled with the fact that he had that high number, confirmed that we needed to submit that to be assessed, and his karyotype was given back to us to indicate he had Down syndrome. We were okay with the Down syndrome. We were just devastated about the hole in his heart.
Mm-hmm. And I was worried that, Dave would be upset that I didn't have the amnio and, that sort of thing. So I was worried that he might blame me, I guess.
Well, we decided when we were going through infertility that we would try to become foster parents in the event that we didn't get pregnant. We wanted backup because I've always wanted a child. And on the foster care application, one of the things they had on there were a list of things you'd be willing to take: pyromaniac children, kids who may have been abused. Down syndrome was one of the things we could check off, and my husband and I agreed that that was one of the things we could handle. So we checked it off, and we kind of think Evelyn was up there saying, I'll pick them to be my parents.
And when Matthew was born, it wasn't a matter of, I mean, I wanted to know he was healthy in the sense that, you know, he had 5 fingers, 5 toes, and that he was breathing fine and not any issues there. But it was joyous from the moment he came into the world. It really was.
The birth of a child with Down syndrome can be a very stressful event for everyone involved, for the family, of course, for the obstetrician, for the nurses in the delivery room and in the nursery as well, for the pediatrician later, for other family members. The extended family is a very, very large one. Unless we've had prenatal diagnosis, many babies with Down syndrome are not identified ahead of time, and so very quickly, within a few minutes of delivery, if that long, many things begin to change.
Unexpectedly having a child with Down syndrome, especially when a family thinks they're not in an age range, for instance, that makes them susceptible, can be a tremendous challenge. When all of a sudden you have a baby who doesn't do very much, as most families know, babies sort of sleep and eat and maybe make some noises and sounds and sort of poop and need their diapers changed. But there's not much that they do. And in that regard, we really are tremendously overwhelmed by the notion that this child is not going to do what we expect them to do. So all of a sudden, the baby is gone, and you have books and videos and advice and support groups and early intervention and how much therapy do you need to do. And what I try to tell parents is, it's going to take some time, but the baby's going to come back, and that's the most important thing. Oh yeah, we have to get our hearing tested. Oh yes, we have to go to the eye doctor. So it's going to swing around, but we're really going to focus on the child, and the Down syndrome I see falls away. What I've noticed is that the Down syndrome is falling away, seems to be falling away a lot sooner than it used to.
The most important thing to say to parents initially is to remember that the baby is a baby first, with the same needs as all other children. I think very commonly parents are more concerned about what's different because the baby has Down syndrome and all the extra things they're being asked to think about, when in fact the biggest effect on the baby's life is going to be the same sort of family influences as affect all other children. So the most important thing is to love this baby and enjoy the baby and play with them and stimulate them in the way that you would have done if the baby didn't have Down syndrome.
When a child is born with Down syndrome, there is a misconception, I think, through the medical community and somewhat into the nursing and the social work community, that all children are alike, that every child with Down syndrome has the same potential, and that is just not the case. We know that in Down syndrome, one of the characteristics is low muscle tone or muscle weakness, but it's not the same in all children with Down syndrome. The potential at birth cannot even be evaluated. We have to look at each individual child with the idea that when we work on muscle movement, on improving muscle strength, that child will then live up to their potential, not the potential that's written in some book about how far a child with Down syndrome should go.
Well, we estimate these days, based on the Genome Project and other studies, that each of us has about 35,000 genes in every cell. And so the child with Down syndrome has an extra chromosome 21, which has hundreds of genes on it, but also has received half of those remaining genes from mother and half from father to make up the genetic complement of the cell. So many traits that the family has, whether they have to do with intelligence or stature or hair color or blood pressure, are things that would be passed on to any child in some combination. We would say that all children with Down syndrome have some degree of mental retardation, that most of our children, if they have no cardiac disease, have potentially never been in a hospital, that things they've heard about relating to Down syndrome may not be true, that their child with Down syndrome may be the healthiest child in their family, that most of the medical issues we face are pretty straightforward medical things, whether it's nearsightedness or hypothyroidism or recurrent ear infections leading to tube placement, things that really any child is at risk for and occurs more commonly perhaps in children with Down syndrome, but are things that we can easily manage. So Down syndrome will always be an important part of their life and their child's life, but those other genes are not to be minimized in terms of their impact and effect on the child.
It would be a disservice to people out there who are biting their fingernails and are losing sleep to think that everything is smooth sailing, because it's not smooth sailing by definition. The issue is how we can get to a place where we can move forward. A very wise colleague by the name of Bill Doherty, D-O-H-E-R-T-Y, Bill Doherty, had made the interesting statement that families have two tasks. The first task when they have a child born with a disability is to make a place for the disability in the family. And the second task is to put the disability in its place.
I think the birth of the child with Down syndrome definitely gets parents thinking about the future. And part of the reason for that, I think, is this notion that what's going to happen to your child in terms of their development, their health, their potential for achievement is somehow limited, or there's a glass ceiling placed upon them. And I think more and more we're finding that that's really not the case, and that as expectations for children with Down syndrome change, and we don't impose this notion of an upper boundary on their ability to achieve, I think we're seeing great things from a number of individuals around the country, and probably in almost every community as well.
There are a group of congenital abnormalities that need to, that will appear early on, or may appear early on, that we need to be mindful of. And certainly the most common is heart disease. Congenital cardiac disease occurs in about 50% of children with Down syndrome. And for that reason, we recommend that all children be evaluated by a pediatric cardiologist as soon as the diagnosis is made. In some areas, and in the United States we're fortunate, we can get a screening echocardiogram which looks at the structural integrity of the heart, and that generally will tell you yes or no immediately. Even in the absence, again, even in the absence of chest cardiac findings of a heart murmur, someone can have very significant heart disease. And we've seen a number of children whose physicians have said, well, we don't need to get an echocardiogram because they don't have a murmur. Well, this particularly in children with atrioventricular septal defect, AVSD, who may have no heart murmur but have serious heart disease, that we need to get this done. So thinking about cardiac disease is number one. We always want to be sure there are no cataracts in the eyes, and that's a usual part of the newborn examination, is looking at the back of the eye with the ophthalmoscope. Thyroid function testing is done automatically at birth in every state. We don't want to miss hypothyroidism, but this is something, again, that we're going to be doing on a regular basis. There are some gastrointestinal abnormalities, but generally they manifest themselves pretty obviously. Children who have a complete blockage of the duodenum will present with vomiting in the newborn period, will not be able to take any food down. And there are children who have a blockage in the lower intestine who may present as well. And then there's the ongoing need to pay attention to hearing. Certainly now there's universal hearing screening in the newborn period. Before this was mandated, however, Down syndrome was always a condition that was a reason for a hearing evaluation because it's a high risk for hearing loss. And not only do we need hearing evaluation in the newborn period, but we need ongoing hearing evaluations.
Communication actually starts from birth. Children are communicating right away, and parents need information right away about how to respond, about what will best facilitate communication. What I suggest is very early on, maybe at a month of age, or maybe, even if the child is in the hospital for a period of time, you may be able to consult with that speech pathologist to learn what to do. Because I think that there are two needs. When should the child start formal therapy? Okay, probably sometime between 6 months and a year. Okay, when should you bring in the speech pathologist as a consultant? Probably immediately.
The job of the therapist should be from the beginning, if you're looking at this child as a child with the potential to have normal speech clarity, and I do with kids with Down syndrome, would be to look at how does this child eat? What are the critical movements that this child is using for spoon feeding, for bottle feeding, for nursing, so that when those muscles are exercised, those muscles in feeding will then be able to produce speech sounds. So we're looking at kids for the example of, if you were talking to a physical therapist, you might get the information that a child needs to learn how to crawl before he or she can learn how to walk. With the speech therapy component, a child needs to learn how to eat correctly with the appropriate mouth and tongue and jaw movements to enable them to have intact or normal speech.
With a newborn, because the child has the low muscle tone and the ligamentous laxity, what is going to happen with the child is that the child's basically going to collapse or fall into gravity. And so what the parent can do is provide the organization for the child by holding them in the right way. For example, holding the head in the center, bringing the hands to the center, and bringing the legs together. And then by doing that, what the parent does is provide the organization. So what the child can then do is regard the environment and pay attention to the environment. Because if they're spending all their energy just trying to focus on their body and focus on moving their body, and it's moving in a disorganized way, they really can't put their attention into anything specific. But as a parent, if you can provide the organization, then the child can focus on your face, can focus on looking at the environment, and what you're going to find is the child will be able to focus better and will even be able to develop smiling and laughing, looking at you, because their whole body is organized in a way that all they have to work on are the facial expressions and moving the mouth.
Newborns actually only breathe through their nose. Breathing through your mouth is actually a learned behavior. So you may see in your newborn child that even a little bit of crusting in the nose may affect their breathing. You may hear that whistling noise. Saline drops, just 2 drops on each side in each nostril, help to soften those crusts, help those to drain down the back of the throat. Frequently you'll see your baby sneeze after you put them in, and that helps to clear the passages. But this is a very safe way to treat it. You can do this 3 or 4 times a day. Very frequently when the children eat, some of the milk may come up their nose. The saline drops after eating will help to clear the nasal passages.
Feeding a baby, an infant, any infant, whether the child has Down syndrome or not, is a very, very special time. That's your first communication. You know, sitting and looking in their eyes, that's the first chance you get to really connect with each other, and you build on that bond, and you become the primary communicator, the one who knows best what your child is saying, mostly because you've had a chance to listen and you've taken the time.
I think it took a while to really get her feeding well. I was trying to nurse, and Down syndrome plus prematurity, you know, made that especially difficult. And so I think I probably would have liked to have more support in that area, maybe asked for more support in that area. Since I had already nursed 2 kids, I didn't really know that I needed that much help.
Some children with Down syndrome at birth latch onto the mother's breast, have a strong enough suckle that they can draw the milk out without any intervention at all. But there are other children that do not. When you have a child with low muscle tone, what you're looking at is the inability to make a firm seal on the mother's nipple. So that would mean that you have jaw weakness, you have the inability to make a suction with the tongue onto the top of the mouth, and you have weakness in the muscles of the lips. So that when the child latches onto the mother's breast, that child cannot draw that milk out. And therefore, if the child cannot draw that milk out on the first feeding, it is the general pattern to say you cannot breastfeed. That's not something you can do. When in fact, instead of saying you cannot, what we need to look at is how can we make your child able to do something which is biologically something that the woman wants to do, something that she would really like to do. And there are lots of ways to teach mothers how to breastfeed children. When a therapist comes in and teaches the mother how to stimulate her breasts through either a breast pump or manipulation to bring the milk in, then that milk supply is given to the child. Now, in addition to that, as the mother is nursing the child, she may have to continue to manipulate or stimulate her breast while she is feeding the child. The child then doesn't have to work as hard to get the milk from the mother. Over a period of weeks, the mother starts manipulating less and less as the child's strength in the jaw, lips, and tongue gets stronger, and then the child will take over and breastfeeding will be as natural as if the child had latched on the first day.
Infants with Down syndrome, when they're first born, if there are no other feeding issues or health issues and they're coming home, are often very sleepy babies. Our son was a very sleepy baby. We had to wake him up to feed him. He lasted for about 2 ounces of milk, and we would have to give him a rest and wake him up. So we had to feed him more often. So you need to be aware of that. There are some things that we didn't know at the time that you can do to alert them, make them more awake and aware so that feeding time is better, lasts longer. Things like stroking their arms, you know, as you take off some of the layers of clothing, and there's a whole oral motor massage that you do around the lips to get them woken up to using their lips for breastfeeding and bottle feeding. Sometimes using a washcloth, sometimes not. You want to listen to your lactation specialist because each child is different.
When Katie was first learning how to breastfeed, I noticed that she, because of her low tone, she really had to spend a lot of energy on trying to get her head in the right place, and she couldn't hold her head at all, and there was a lot of movement. So I realized that early on, and I cradled her much closer and with a lot more support than I did, like right around her head, than I did with Hannah. Hannah even, you know, could turn and not hold her head up per se, but she didn't have any of the extra movement that Katie had. And so in order for Katie to put all of her energy into the suckling, I felt like I had to really, really support her body and her head in the right position, and I think it made a big, big difference.
William had the open heart issue. He had a huge hole in the middle of his heart, so the 4 quadrants were not formed. And one of the things that the doctor said before we left the hospital, Dr. Green,